Thank you so much, first and foremost, for being here. My name is Jonathan Webb. I'm the CEO for the Association of Women's Health Obstetric and Neonatal Nurses. And it's a pleasure and a privilege for me to be sitting amongst these leaders and with you. I just wanted to offer to you, on behalf of the patients that we serve and the individuals that I engage with in my network, a hearty thank you. Because I know that the work that you do may sometimes be thankless, and there are challenges you experience, but it's so powerful to me to be in this environment, to have all of you connected in this way. So thank you for all you do. I'll ask you to humor me for a moment and turn to one of your colleagues and give them a high five. And then I'll ask you to turn to your second choice and give them a high five. Again, one of the reasons why I think this is important, and I like to start with that, is because we are team members. We all play different roles in supporting our patients. And teams acknowledge the work we do by giving each other high fives and giving each other encouragement. So again, thank you for all that you do. I wanted to start, before I invited these individuals on the stage here to introduce themselves, by sharing a patient story with you, because I think it's important that even though we're doing different things in different spaces, and we've heard a number of presentations that get into the political weeds or the process weeds or the technological weeds, that we remember and center the voices of the patients and the people that we're serving. So I wanted to offer a story of a gentleman I met. I moved to Virginia a number of years ago, and there was some work that had to be done on my house because there were some issues with respect to code. So we had a relationship with a contractor who brought a crew to the house to help us address the issues in there. Part of his crew would come by, and this work would last for several months, and they would come by every day, a hardworking group of individuals. They were there from 9 to 5. And one of the individuals I had a chance to meet, his name was Chuck. Chuck was older gentleman from West Virginia. He is full of life and energy. He would tell jokes. He'd be working outside, and he'd have his music blasting. We learned, because of the connections that we had over the course of our time together, that he loved country music and rock and roll. So we had a healthy dose of that for a few months. Every now and again, when something didn't go right, you'd hear an expletive that was heard over the rock and roll music. But Chuck was a good guy. I learned about his family. Chuck had a couple of adult sons. Chuck was working from job to job doing the tasks he was working on for us. And at the time, I was working for the American Diabetes Association, and I think Chuck may have seen a logo on one of my jackets, and he shared with me that he lived with type 1 diabetes. So over the course of our time, I would check in on him to see how he was managing his illness, if he was maintaining his medication, how he was getting along. And one day, I came home from work, and Chuck was having a snack in his pickup truck, and I asked Chuck how he was doing. He said, "Well, I'm having a pretty low day today. I'm not feeling too well." And I asked him what was wrong. He said that he's a type 1 diabetic, as I mentioned, and who would take insulin shots every day. He said it had been several days since he had taken his last shot because the cost of his medication had gotten so high that he was spreading out his dosage and trying to manage his care that way, because he had more, in my vernacular, more month than money. And I was able to, in that role, then share with him some resources to help him at least navigate the challenges he was experiencing. But I don't think that it's right that people like Chuck have to live in that kind of condition every day. Which brings me to why I think it's really important for us to have these type of conversations, because I know our charitable patient foundations are really working to make sure that those type of situations don't happen by offering financial assistance and support. And with changes in the Inflation Reduction Act, there may be some relief coming, but with that comes some uncertainty and some challenges. So I'm really looking forward to having a discussion with all of you today around what you're seeing as opportunities, challenges, what you're experiencing with respect to patient access and equity, and just sharing with all of your team members what's on the horizon. So with that, I'll start with you, Tiara, and ask you to briefly introduce yourself.
Absolutely. I'm Tiara Green, Interim CEO for Accessia Health.
Clarenda Wally, President and CEO of Good Days.
I'm Fran Costello, the President of Operations for Patient Advocate Foundation. And I'm Kevin Hagan, the President and CEO of the PAN Foundation.
Thank you all for being here. Tara, I'll start with you.
Sure.
What do you see as the top long-standing and emerging challenges that patients who come to your foundations are faced with?
I think we've been hearing it over and over in this conference, but it's something that we hear every day, and that patients are struggling to afford their health insurance premiums, their co-pays, and their other health-related expenses. We talked here about inflation. We know that the cost of everything has increased, from gas to food. I don't know about you all, but everyone has had an increase in their grocery bill. So they are trying to manage their care while managing all of these other expenses at the same time. On top of that, we have this benefit of there being new generation or next generation medications that can target different conditions, but they come at a cost. These individuals have to pay for testing to make sure that they're a candidate for some of these different treatments, and they may not necessarily be covered. So we have millions of Americans who are having difficulty affording their care. And sometimes they're doing it alone. And no one should have to go at it alone, which is why we all exist, to step in and be the safety net when they need it.
Thank you, I appreciate that. Fran, would you like to respond to that also?
Yeah, I mean, I think I would echo what you said. I think one other kind of complicating factor that we've identified over time is it matters where you live. There are significant disparities among healthcare access. I think we all can agree to that. Even within my own programs and my own data, there's places that we should be serving people in communities that are very vulnerable, and we're not. And you have to really wonder why that's happening. So there's programs like ours, and there's other safety net programs that are, we desperately need to do a better job getting that information into the right people's hands in those places, so that those folks that aren't even finding us to tell us how difficult their life is. And they're probably, most likely, some of our most vulnerable people living with the least healthcare access. So I think that's a really important message to definitely talk about the patients we're reaching, but also to really hone in on those we're not reaching.
I think that's such a great point. I want to come back to that in a second, but I'll ask you to ask the same question of you, Kevin, some of the challenges that you're seeing that your patients are facing.
I mean, of course, I agree with the comments that both of my colleagues have made. And sort of tagging on to Fran's point about health equity, I think it's an area that I know at PAN we take very seriously, and I think all of the foundations now, the independent copay foundations, are really trying to understand what this means and how we can better address those disparities. At PAN, we're undertaking initiatives to really understand the demographics of our patient population, what those demographics and how they compare to prevalence of the disease states in different populations, and how we can better target and serve, particularly those underrepresented communities that do lack healthcare access. So I think that's sort of the emerging challenge for all of us today around sort of the health access piece. But then, of course, and I'm sure we'll talk about it later, there are many other challenges, I think, just sort of collectively as a copay industry and patient assistance industry that we'll be facing.
So I want to build on that last point and toss it over to you, Clarinda. So if we zoom out a little bit, you can have an opportunity to respond to the first question, but if you zoom out a little bit, what are some of the challenges that you're seeing from a Charitable Foundation standpoint with the larger landscape?
Well, again, as we talked about, there's disparities across the country. And it's not just access to financial assistance to get medication. How are you going to get to the doctor's office? Right. You have nutritional needs with many of the diseases in which we're providing assistance. How are you getting that nutrition? So when we look at how we're all serving individuals, you've got to look at the whole picture.
Yeah.
What is their family life like? Do they have access to nutritional food? Are they seeing the correct provider? Some of the disease states that we're dealing with, you have there might be 10 specialists in the country. Mm-hmm. How are they going to get to that specialist? And so, it's the biggest picture is how do we ensure that the circle doesn't have gaps. Ensuring that, one, your disease is identified, you get diagnosed, you get access and affordability to the treatment that's going to save your life, getting to and from, the logistical problems with that, and then it goes to nutrition and education. And, I think that with every disease, whether it's preventable or unpreventable, the healthier you are, the more active you are, the better your disease will go. And those are proven scientific facts. And it's unfortunate that you see these disparities across the country, and many times with people of color. On what can we do to access, because it's more than just financial, it's also education. How do we educate the culture without changing it? And I'm American Indian, I'm Navajo, and I'm Spanish. You saw COVID hit us hard. Why? Not because it's prejudice, it's because type 2 diabetes, obesity, alcoholism, all of these things. And so, how do we come in to all of these different cultures saying, we don't want to change your culture, but let us help you help yourselves. Again, this is the first time in our time that our children are predicted to live a lower lifespan than we are. So it's the whole circle.
So I so appreciate that comment, and kind of the dovetails back into one you raised earlier, Fran. Are there any specific strategies or approaches or recommendations for how you educate or engage communities respectfully and get out into those spaces that where people may not normally be coming to you? So
for us, we're starting small. We've reached out to, so there's a hospital center in South Texas, in McAllen, who has desperate need. There's a huge Hispanic population, and so they have these different needs. So what we're doing is we're going to the hospital, we're working with them to try to identify the needs of that community, and build programs around it in the hopes that if it's successful, you live and learn what's going to work, then we can move it elsewhere. The next place we're going is we work with Morehouse School of Medicine out of Atlanta. Again, identifying another community and say, what are the needs and what can we do together to address them? And I think you start small, because how do you eat an elephant one bite at a time?
Right.
That's right.
Well, and I think that conversation with the impacted community to understand what they need and how you're engaging is a great example of how you demonstrate cultural competence and humility as you're coming into the new spaces. Anyone else want to respond?
Just adding to that, and I say this frequently, is that sometimes the zip code is more important than someone's genetic code and their genetic makeup. And it should not necessarily be like that here in America, where we have all of these different advances in medicine and resources to help individuals. I know for Accessia Health, our goal is to work with specific communities. So we are partnering with an organization in Louisville, Kentucky, and it's going with a faith-based approach in that we are going where the people gather. Right. It is a specific zip code, and it is individuals who are African American and do not have access to care. Well, where do they congregate? They go to the church. So we are engaging community health workers to continue to bring them in, and then in return get them the health care they need. But it's all about social determinants of health, and everyone up here has really pinpointed that we have to look at all of those aspects if we are going to help people do better, not only from an intervention standpoint, because it's intervention by the time they get to us, but from more of a prevention standpoint as well.
The holistic approach.
The holistic approach.
It's so spot on. And Kevin, Fran, you want to respond at all? Or?
Yeah, I mean, I can add, the approach that we've taken at PAF so far is to listen and learn, go into communities. We've been about 7 or 8 years working in various communities to learn from them. We're not the expert. Right. We don't know what's there. We don't know what's needed. So in some of our strategies, we're very much on the ground, and we're learning from those communities, and we're bringing the resources we have to bear as a national organization to them. This past 2 years, we really were determined to find a way to use charitable patient assistance in a way that could be a tool of many that could bring some relief and some support to people living in vulnerable places that were not connected to us. And I'm going to say us as an industry because I think it's probably similar across our data sets. And we've been able to establish several, 15 now, health equity funds in our copay program that have all the same rules of the road as all of our funds always have, but they have a geographic target to them so that we can actually bring some much needed financial support into very vulnerable communities. And we use CDC data sets, the Social Vulnerability Index that they published in 2020, which helped us understand as a country the kind of stability or lack of stability that certain communities have. And then, you go one layer down and you can make some really solid assumptions of the people living in those communities too have less access to lots of things. It's not just healthcare related. So that's been an interesting strategy to see unfold. And, we've seen a significant number of people in those places now getting some help that they weren't getting. But more importantly, we've made connections to FQHCs, to nonprofit organizations that are non-traditional, so like food banks and like churches and places that people go that aren't healthcare related, to connect patients to this resource. So the medical community and all of you as advocates are our number one resource to connecting patients to all of our programs, but you're only so deep. We need other organizations and people in these communities to really help people understand what resources and safety net programs are available to them.
I appreciate that comprehensive approach to team, what your team looks like. Kevin, I'm going to toss a different question your way.
Yep.
Several Medicare Part D reforms will go into effect 2024 and 2025, lowering out-of-pocket costs to $3,250 and then $2,000 for Medicare Part D covered treatments, along with an option to smooth these costs throughout the year. Can you explain these reforms and what will the impact be on patients?
So, the Medicare reforms that were in the Inflation Reduction Act are some of the biggest changes we've seen as sort of an industry in probably a decade at this point. And I will tell you at PAN, we've long had an advocacy program where we've advocated for many of these initiatives to lower out-of-pocket costs, including our team has done significant work on this smoothing component. And this concept of smoothing actually came out around 2014, 15, I believe, through a challenge that PAN offered. And a professor at the University of Pennsylvania, this was the winner of the PAN challenge, this concept of smoothing. And, patient advocacy groups have sort of adopted it and pushed it through to get it included in this legislation. And while there are so many great things about this in terms of the elimination of the 5% coinsurance starting in 2025, which will effectively, or 2024, which will effectively have a $3,250 cap for most Medicare beneficiaries, to 2025, where that cap drops to $2,000. That's great. And we are really excited about those changes, but the reality of the situation, and I think all of you as patient advocates in the room will know, that $2,000 a year is still a lot of money for a lot of people. So we know there's a continued patient need. At PAN, we've done some polling of Medicare patient populations, and 75% of them are saying a $2,000 out-of-pocket cap is still high for them. And when you look at Hispanic and Black populations, that jumps up to 85% and say that $2,000 is a real burden. And we know that there's going to be a continued patient need. We've seen it in some research that PAN commissioned with Avalere Health, which talks about the continued need, and there will still be a significant number of Medicare patients who will be spending 10% or more of their income on their out-of-pocket costs. And we just know that's unsustainable. And I know all of my colleagues here, we're constantly working on what it looks like in 24 and 25 for our patient assistance amounts. But we also know that the need still exists, and it's going to continue to exist. And my great fear has always been that this kind of reform happens and people think, oh, well, we've got it taken care of. And I think, history has shown us that we don't have access and affordability taken care of even as new pieces of legislation may incrementally improve patients' experience.
As you are offering that response, I think back to my buddy Chuck I mentioned, and as it's moving in the right direction, but I still think that would be a hardship for individuals like Chuck. You look like
Yeah, well, and there's a little more to it than that. Well, you talked about it earlier, you hit it. You said, okay, so inflation 30%. Did these Medicare recipients, did their Social Security go up by 30%? Absolutely not. Did the price of bread go down? No. Now you have a new standard of what things are going to cost. Your money is going not as far as it used to go.
Exactly.
So $2,000 in 2024, 2025 is no different than $4,000 3 years ago. Everything went up. I mean, even just looking at those of us in this room who have commercial insurance, did we all get a 30% raise?
Right.
No. So things are still going up. The need is still there. I mean, we all fight for these types of changes to take place. But the problem is the people that we support might make $30,000 a year.
Yeah.
Food, cars, housing. They're already in poverty.
Yeah. I saw you lean forward, Fran, like you
Yeah.
were getting there, so go ahead.
I think too, sometimes we lose sight of everybody else too. Not everybody is a Medicare beneficiary. And I know that there are manufacturer programs that solve a need. So a single drug, which are very useful. But I think there's a very legitimate concern that there will be some cost shifting that will happen into the commercial population. All of us will be paying more. These companies are not going to take a haircut just because the government decided to put a cap on the Medicare out of pocket. We all know that. I see a lot of smiles. So where is that money going to come from? And I think it's going to come in the form of increased premiums, low cost drugs that now, pennies on the dollar, and now they're $5, which for some people might be too much if they have too many of those. So I think there's, when we talk about the IRA and the Medicare reform, we have to really paint that bigger context. Because I know all of us, while we serve a tremendous number of Medicare beneficiaries, because we're one of the only, if not the only resource that can do that, we do have a segment of commercially insured folks that are our working people.
Yes.
And they're not getting 30% raises, and they're getting inflationary environment plus, So I think that's really important not to lose sight of the whole population, because it's not just Medicare that gets sick.
That's such a great call out. Did you want to weigh in, Tara?
I'll add two things. One is that we're only talking about co-payments, right? There's other things that these patients have to pay for. Their diagnostic testing is not going to change. So the health of the whole person, as we've been saying, there's still going to be a gap. Second thing, it's a numbers game, right? I read this stat that said over 10 million households led by someone over the age of 65 is cost burdened.
Yeah.
And half of those individuals will spend half of their funding or their money on living expenses. So they're left with, we're thinking $40,000, $45,000 income, right, per year. That's $20,000, about $1,500 a month now to live, to pay for all of the items that we just mentioned. They still need help.
We've been touching on it a little bit here, but I'll toss it out to anyone who wants to build on any other policy issues that you're seeing that are germane or relevant to the landscape, the future landscape.
Well, I'll jump in, and it's sort of tagging onto some of Fran's comments about looking at the broader sort of landscape. But, I think there are always unintended consequences to legislation, right? And I mean, we were supportive of these Medicare reforms. This is good for patients. But what we don't know is how the market is going to react, right? And so one of the things is, what does restrictive utilization policies begin to look like? Are insurers going to start dropping coverage for certain aspects or certain pharmaceuticals? Are they going to move things to different tiers to make them, less affordable? we're also beginning to see the rise, and I'm sure a lot of you are seeing it too, of these alternative funding programs, which, I think all of us are concerned about, but PAN specifically has come out with a policy statement around our opposition to, and we're working with a collaborative group of patient advocate foundations to really talk to Congress about what this means. And really, these alternative funding programs are excluding drugs for people who are technically covered by them. They're saying, okay, we're not going to cover this drug anymore because you can go to these patient assistance programs and get it, because now you're going to be deemed unqualified, uninsured for it. And what that's doing is just creating a burden on the safety net that we offer to patients, because people who should be covered for a drug by their insurance company has intentionally excluded it to try to save money and pass that cost along. So, I think these are the kinds of things that I worry about. At the end of the day, how does the whole ecosystem respond to the changes? And I think that's the uncertainty that we all live in every day, because we're not sure yet. And I don't think any of the players are really sure yet.
No, and as we move, it takes years to get any one of these pieces of legislation put into play. Then when Congress changes through the elections, you're starting over, re-educating people on, okay, this is why it was important. This is who is affected by it. So it's like push, 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 and then sometimes there's the silver lining, and policies like this come into play that can actually benefit individuals.
Good, Chair.
No, I was just going to add to that. We heard earlier about copay accumulators. We are all familiar with copay accumulators, and I know there's a session tomorrow as well. But it is still an issue for so many patients. We have, 18 to 19 of the states that have banned it, but they're banned it, I should say, not abandoned. But there's so many other states that are allowing this type of behavior. So when patients come to our organizations for assistance, we can assist up to a certain amount. What happens when they exhaust that? Yeah. Now, they're starting back over and they haven't met any of their out-of-pocket costs. So it continues to be an issue.
Yeah. Thank you for bringing that up, Fran.
Yeah, I don't think I can add anything to what you all covered. There's certainly all of these, I said shenanigans yesterday, I'm going to use it again today, that payers use to control cost, and employers are now using to control cost. But I would like to turn it a little and say that there's some opportunities here too that don't keep me up at night. Well, they do, because they're big picture ideas. But I think we've got to move upstream a little bit. It kind of back to the health equity conversation. There's been some recent rulemaking that requires certain Medicare plans to do a social determinants of health screening, for example. Yeah. We have an effort afoot within our own organization and our sister organization, National Patient Advocate Foundation, to really engage with policymakers and partners to hopefully, we want to really build out and scale the idea of social needs navigation for all, right? And it's not PAF doing this, so this is not a plug for what we do, but this is really, everybody deserves to be asked certain questions about their life and their circumstance before they're in a crisis. We're all reacting, right? Like, we're all reacting to somebody calling us and saying they need a grant, they need help, and you guys are too. It would be so much better for everybody if we could standardize and codify a requirement that you do a screening, but not just the screening, because there's lots of those going on in different places. Yeah. But we have to also have, through policy reform, kind of, if we're going to do the screening, you got to do something about the results.
That's right.
Have some actionable kind of resourcing that is kind of baked into the healthcare system. It's part of the process, right? It's part of your intake. It's part of your diagnosis conversations. It's part of the whole continuum. It's not this, oh, and by the way, there's some resources if you need them.
Right.
But we're not sure if you need them.
Right.
So I really do think there's some opportunity and some appetite at a policy level, whether it be big P like, on Capitol Hill policy, or little p like within health systems, to really to sensitize and scale an effort of that nature to the benefit of everybody
Right.
going through our healthcare systems.
So I'm going to sort of tee up a question that'll come later, but I'm going to ask all of you to start thinking about some of the opportunities that you'd like to share, so things you're looking forward to in the new landscape. So start thinking about that. But I'm going to stay with you for a second, Fran, because I know we have a number of patient advocates in the room here. So I'm going to see if we can get behind the curtain a little bit for folks. I know it's challenging for patients and those advocates who support them each day when a fund that a patient desperately needs is closed.
Yeah.
Can you give us a little bit of insight on why those funds close?
Yeah, I can. I think we'll have the same answer here. I was joking earlier. I have been doing this for 23 years, and it was around when PAF started their copay program in 2004. And to say that it's the most painful thing to do, I mean that. We wrestled with it for years, the first few years of our program, like, how can this keep happening? We feel like we're disappointing people. And then we had to get comfortable with the fact that the resources are always going to be outpaced by the need.
Yeah.
And so what you have to do as an organization is find the best way to make the money go the farthest with the policies and procedures that you put into place, and make that money available as fast as you can when it's not being used by somebody else, for example. And when you get a new donation, get it right out into the public. And then stop taking applications when you've given all that money to the people who need it.
Yeah.
Because if you don't, and you just hope that the pot's big enough, eventually you're going to disappoint somebody because you've taken too many people and now you've set false hope. So it's really a choice of, are we going to disappoint you a little on the front end, but make sure you have the money for the patient you're working with for that 12 months, or are we going to take everybody, make everybody happy on the front end, and then disappoint you badly on the back end when you put a claim in and we're like, oh, I'm sorry, we don't have any money for you. We made the decision to do the former. I think most of us do that. So it's challenging, guys, and that's, just the fact of these programs. The funding, we are charities. We're independent 501c3s. We raise money just like every other charity that you probably give to. We have development folks. We write grants. We do fundraisers. We do individual campaigns. We have black tie events. Like, it's no different than other charities, and therefore the money ebbs and flows. So we appreciate your patience, and just know that we're all working very hard to always have money, as much of it as we can, available to the patients when they need it.
Thank you for that, Kevin.
Well, and I absolutely agree with that. And we do the same thing. We give you the grant for the year, so that you have that security for the year of your grant program. But one of the things that I think is really helpful, and this is something PAN did years ago, and all the other copay foundations graciously allows us to do it, is we launched Fund Finder. And it was because of the disappointment, right? Like, we didn't want to constantly have to say that fund is closed, particularly when we knew they could get help in other places. So we created Fund Finder, which actually collects all the data from the copay foundations. So it allows a patient, or you all, to go in there and see, yeah, PAN may not have it open, but maybe Good Days does, or Cessia, or Patient Advocate Foundation. And you can see which ones are open and currently accepting applications. And I think that's just a tool that is helpful for patients to know, and for you all to know as well. As we all face these challenges. I mean, we want more money in those funds too. And basically what a closed fund means is there's more demand than there are resources to support it. And I know a lot of us, not all of us, maintain wait lists for priority wait lists so people can sign up. And, that is helpful. And I'll just tell you, if you have patients I would encourage you to put them on the wait list because it also helps us tell a story when we're talking to donors. If we have 15,000 people on a wait list waiting, that's a powerful story that we can help sort of encourage donations in those disease states.
So I'm going to stick with, anyone else want to respond to that?
Well, I think the other thing we can do, because saying no is difficult, is offset costs someplace else. So if there's not funding to pay for copays, is there funding out there that can help offset that household cost so then they could afford their treatment? And that's pretty much going through every advocacy group in the country to say, okay, what is available? Going to communities, is the church giving anything? Is there any other way that we can offset household costs
Right.
so they can continue to afford their treatments?
Going back to seeing the whole person.
Right.
Okay, makes sense. Kevin, what do you wish patient advocates, healthcare professionals, and the wider healthcare industry knew about charitable foundations?
What I think would be really important for you all to understand is, we are on the same team and we want to help support the work that you're doing. And there are ways that you can help support our work too. Clearly sending patients our way is a support to us, but also using your voices to help advocate for some of these changes. I mean, you heard some comments today around the copay accumulators and how some states are banning them. I mean, you all reside in a state. And those advocacy efforts that you do, engaging with our advocacy teams around these policies and talking to legislators either at the state level or the federal level, and I know we send out advocacy alerts, I'm sure the others do too, that helps us help patients. So I would say that that's an important thing that you can do. And then as you're engaging, just talking about the continued patient need. I mean, I did have this worry when the IRA passed, and Fran, in our prep call made the comment. She was like, yeah, we've thought this issue was resolved around access and affordability many times before, but a law passes and then it never actually gets resolved. And I think just that continuing narrative is really important for the public to understand, for legislators to understand, and honestly for our donors to understand. Because what we don't want them to do is walk away from the independent copay foundations, particularly because we are the safety net for the 65 million Medicare recipients. They don't have another option except by coming through us. So.
Thank you. Terry, I'll ask you if you want to expand on your thoughts, what you'd like to.
I echo those same thoughts. At the end of the day, we are charitable foundations, right? We rely on the donations of individuals who are able to provide some funding so we can assist as many patients as possible. And that is our goal, to assist as many patients as possible. So using your voice, advocating, understanding all of the patient's needs beyond just their copays for their medications, and looking at those social determinants of health so that together, because this doesn't rely on just one field or one organization, but this is us working together, we could meet the needs of those patients.
Okay, thank you. Corinne?
I echo all of these thoughts. In the end, we're here to help people. And, that's our motivation every day. That's our why. It's the people. And, as we sit here together, we collaborate often because it isn't about what can Good Days do. It's what can we all do together to help one more person, one more family, one more community.
Yeah. Well, I think that's important. I'll come to you in a second, Fran, but I think that's important. As I started this discussion saying, the strength of having all of you foundations on the platform together sharing these insights, to me, speaks to the strength of the collaboration and the willingness to work together, which I think in the end benefits patients.
Absolutely.
Absolutely.
Fran?
Yeah, so I'm going to go, I fully agree. As I said to Kevin, there's been a few very pivotal points in healthcare reform that we really did think we had it licked and maybe we could all go home, seriously. But that did not happen. And I think the Medicare reform is an iterative process. I think it will continue to be.
Yep.
And that is one thing you can do, is advocate for reform for Medicare beneficiaries. They're most all on fixed incomes. They are our most vulnerable population. We do have an obligation, moral obligation, to care for them That's why Medicare and Social Security were started in the first place. So I think we can't ever forget that. But one thing I would love for this audience to know as users of our programs is the complicated compliance environment that we all live in. And it's not your business to have to understand that in and out, but just understand there's a lot of it.
There is.
It's a far different environment from an operational perspective and a governance perspective and a fundraising perspective than most any other charity, even inside of healthcare. So, give us your grace and your patience when you don't necessarily always understand some of our policies and procedures and why we do things. And we're all very similar, but we all do things a little differently. That's because we all have an OIG opinion that's very similar, but a little bit different.
Yeah.
So we may see some differences between us, and I just think that's really important because there has not always been that awareness, because it's not, you're kind of on a need to know, right? But we need you to know that it's complicated.
You use one of my favorite words. I think we could, as a nation, use a lot more grace.
Grace.
Yes.
In all we do.
Go a long way.
So as we're starting to close down a little bit, we've talked about some of the challenges, the opportunities. I think you've all done a fantastic job, in my opinion, of painting the picture for us of what's to come, what's on the landscapes, and giving us some insight behind the curtains. I do want to make sure that we have an opportunity to talk about the positive pieces. So what are some of the things you're looking forward to in this new landscape? And I'll start with you, Kevin.
So I would say one of the things we're looking forward to is the relief, particularly around our senior populations on Medicare. If funding remains at stable levels, we'll be able to help more patients. So more patients can actually get the assistance they need to stay on therapeutics. Now, that's a big if our funding stays stable. And I think that's a message that we've all talked about collectively is, this concern that do we have it licked or can everybody afford $2,000, which we know they can't, and our donations drop. But I'm optimistic that this is going to help a lot more people. And I think there's a real story potentially here that time will tell. And that is, there were people who knew their co-insurance and their copay out of pocket at $8,000, $10,000, $12,000 a year was not feasible for their family or their life. But at $2,000, it may be. So what we may see is actually more people coming on to therapeutics and entering into treatment because maybe there's a chance they can make that $2,000 work, whereas they wouldn't even attempt to try it and then have to come off of it if they couldn't afford the $8,000, $10,000, $12,000. So I think that's sort of the hope and the opportunity that I see for the future is that maybe we can help more people than we're helping today.
Fran?
Yeah, so I think charities are like, we rule the world. And if we left the building, like lots of things would fall apart. I don't think the government realizes how much independent nonprofits of all sorts and all industries do for our country and the citizens of our country. So I'm excited about the opportunity that we have as charitable PAPs, but also at the broader healthcare advocacy community to really be champions and be actively involved in that upstream work of screening people for, those social determinants of health, really understanding where they are in life and thinking more holistically. We've talked about that for a long time, but I don't think we've done it very well. We've got a lot of Band-Aids, which are awesome altogether, but I'd rather, do it a different way. So I'm really excited about the opportunities that exist to think outside the box a little and be more active listeners and more engaged helpers.
Thank you. I was going to say, you talked about charities ruling the world.
Yeah.
I think Beyonce might disagree with you.
The big girl.
That's right.
Sorry, that's it.
Okay, right behind her.
Sorry.
But I agree with you.
So no, again, it's the opportunity to touch more lives, give more good days, and hopefully, like through these types of changes, we as foundations who provide assistance can continue to work together to look at the legislation that is coming or opportunity for new legislation, and come together as a community. You know, I'm touching 350,000 people a year. That's a lot of voices from a lot of communities and a lot of constituents in every one of those states. And I think that we should continue to work together to use the power of the numbers we have to make positive change for the people we serve.
Makes perfect sense. Makes perfect sense.
I want to echo what Fran was saying. I've been in the public health field. My background is in public health, community health education, and we have talked about health equity for so long.
Yeah.
And they have just been words that we kind of like throw out there because it's like a buzzword. Like it's health equity, it's health equity. But I feel like we're finally getting to a point, and I'm hopeful, that we are getting to a point as a country where we are putting action behind those words. I tell my team all the time, words are great, but if you don't put action behind it, it means nothing.
Yeah.
So I'm really hopeful for what's going to come and how we reach diverse populations and how we can assist on a different level.
I've been in public health for a while as well, and it has become a part of our normal vernacular now, moving more towards accountability, I think is the
Yes.
next step. So I'm
Yes.
glad to hear that as well. Well, I know we're at time here, so I want to thank you all for being here. Please give them a round of applause.